I think it is working now. Dr. Arghya, is it working now?
Yes, it is.
Okay.
सर्वे भवन्तु सुखिनः सर्वे निरामयाः सर्वे भवन्तु दुःखभाग्ये शांति शांति.
With that, we program. Dr. Akash, can you share your slide, please? Today's we are divided into 3 parts. The discussion. The second part is a presentation on tips and tricks of one lung ventilation and lung isolation, and the third part is the quiz, and already stated. So a case discussion on anesthetic management of a patient with myasthenia thoracoscopic thymectomy. And today we have Dr. Amya Kumar Misra, Assistant and HOD Anesthesia, Perioperative Care and Pain Management. He will be our mentor today. Dr. Jaya, Senior Consultant of the same department, with me will be the moderator. Din BPG will be the so let's start to Dr. Please.
A very good evening, everyone. Today we are going to posted for wax thymectomy. Recently, successfully performed by Dr. Before we proceed with the discussion, I would Dr.
Good evening, ma'am. This case is of a 41-year-old female who was diagnosed with myasthenia gravis and was scheduled for a the patient presented with progressive difficulty in breathing, drooping of eyelids, that is ptosis, and a blurring of vision since 7 months. Generalized presented as inability to walk, difficulty in raising arms, and the patient was on pyridostigmine 60 mg 5 times daily, mycophenolate mofetil mg twice daily, and prednisolone 30 mg once daily. A CCT revealed an anterior mediastinal mass which was thymoma. Patient received IV Gravis, crisis, and planned for a wax thymectomy.
Any disease helps us. Can you briefly explain the pathophysiology of myasthenia gravis?
It B-cell mediated autoimmune disease in which antibodies bind to acetylcholine receptors at muscular junction related specific kinase, lipoprotein or agrin, decreased functional decreased amplitude, and initiation of muscle fiber contraction fatigable weakness. There is a bimodal pattern of incidence, approximately 30 years, and occurs more commonly in women. The incidence of late onset disease, that is more than 50 years, increases with age and is more common in men.
Is there any other syndrome that mimics myasthenia gravis, and how would you differentiate between these two?
Is known to mostly associated with the thyma, whereas Lambert syndrome is associated with the small cell of the lung. The antibody target is the postsynaptic acetylcholine receptors, the mask antibodies, or the LRP4 receptors in myasthenia gravis, whereas it is the presynaptic with the ocular progressing to limb and then bulbar weakness. It usually presents with limb weakness and ocular, and in myasthenia, autonomic dysfunction is quite rare, which is syndrome. The deep tendon reflexes are normal in gravis, whereas they are reduced with exercise. Exacerbates in myasthenia, reduces.
By history and differentiate these two syndromes very well. Clinical features of myasthenia, the typical history and examination find myasthenia.
The patients usually present skeletal,
which involves different groups of
face, etc. Symptoms may over the course of the day. Often they have normal muscle strength in the morning, and symptoms the use of the affected muscles, and strength returns with rest. There can be diplopia, orthosis. There can be difficulty or speaking due to bulbar dysfunction. There can be dyspnea due to respiratory muscle compromise of the on exam muscle articulations and remain normal. Cardiac involvement can be there and can mild hypertension, and there can be first degree AV blocks with dysfunction can also be there.
Basically, the symptoms of myasthenia can be divided into groups. One group of symptoms are because of the effect of neuromuscular you have mentioned just now, but the other group of pressure symptoms, which are because of the thymoma. Any cough or dizziness, especially if they're pressure, this would help us rule out any vascular compromise. Also, during history, it is important to ask about any history ventilation due to severe respiratory deficiency. These points that you would like to ask for during history. Would you like any other associated with other autoimmune diseases?
Myasthenia gravis is often associated
with other conditions which share an underlying autoimmune tendency. There can be diabetes, that are quite common in myasthenia. Immune diseases are rheumatoid, SLE, scleroderma, sinusitis may also occur.
As you mentioned, these variable presentation, is it possible and based was the disease severity of your patient?
Myasthenia gravis can be classified based upon its clinical presentation. According to the Myasthenia Gravis Foundation of America, There are 5 grades. Grade 1 is any ocular weakness, other muscles is normal. Class 2, 3, and 4 are mild weakness other than the ocular muscles. Class A and subclass B. Subclass A is predominantly the limbs, axial muscles, or both, and B is predominantly pharyngeal, respiratory muscles, or both. 5 is intubation with or without. According to the MGFA classification, our patient had a 3A.
Okay, Akash. Drug free is very pharmacological treatment modalities available for myasthenia patients.
There are 3 main approaches to therapy. First is symptomatic treatment with acetylcholine. Chronic immunosuppressive therapy with corticosteroids or non-steroidal immunosuppressives like azathioprine or cyclosporine. And there are immunomodulating treatments like IVIG and plasma exchange or plasmapheresis.
Are there any agents?
Agents do have anesthetic. Corticosteroids may lead to electrolyte abnormalities such as hypokalemia, may cause hyperglycemia, adrenal suppression, which requires supplementation with exogenous steroids as well as post-operative suppression, hepatotoxicity, hypertension,
bone marrow suppression. Plasma can lead to citrate-induced hypocalcemia and hypotension, and IVIG can lead to hemolysis and aseptic meningitis, AKI. These conditions accounted for during the pre-anesthesia checkup and
Anticholinergics. So during anesthesia, the neuromuscular blocking agents, isn't it? Given it cause even cholinergic crisis. So we have to be careful about those agents as well. After detailed history and examination, what investigations would you like for these patients and why?
Count is to be as because of the presence, there may red cell aplasia, bones may have pernicious anemia, creatinine, liver function, which also depends upon suppressants that are being used. Thyroid dysfunction common, hence research needs to be done. Chest X-ray may or a mediastinal, and pneumonia, which is particularly in bulbar weakness. ECG to rule out atrial fibrillation, cardiac involvement, a 2D, and pulmonary need to be done to obtain a baseline.
So Akash, you just what PFT findings do you anesthesia? PFT parameters if
Expiratory flow rate less than 40%, and with mixed secondary to vital capacities of 65 to 70 predicted prediction respectively. Vital capacity of less than 2 is forced vital capacity that integrates inspiratory, reproducible, and easily performed investigation.
so now as you've investigations before finalizing the anesthetic are you looking at while reviewing these images?
A CT and an MRI of chest can provide involvement. Additionally, MRI provides details regarding dynamic position related changes.
Okay, Akash, now post significant concern in these patients. Predictor myasthenia gravis is predicted beforehand.
There are certain factors which, if there is pronounced decremental response more than a negative inspiratory force of less than 40 to 50, intraoperative blood loss of greater than 1000 ml, operative ventilation.
So, Akash, during preoperative evaluation, that this patient's disease is not well controlled. She still has respiratory muscle weakness. This patient for thymectomy. The optimum timing to perform elective surgery in these patients, prepare them for surgery, minimize their surgery, and measure we would like to take to prevent perioperative pulmonary complications in these patients.
Minimal manifestation status, which is defined by MGFA as no limitation, but some examination of some muscles. But this may always be IVIG may be used in these patients, particularly bulbar dysfunction and the patient's neurologist should be involved so that the condition is optimized and phase before the surgery, and other preparation management of other comorbidity may have, incentive spirometry, other associated conditions, particularly dysfunction.
Akash, now your patient is optimized. You have to take an informed patient. What are the specific points you would like to do with this patient?
Respiratory events includes arrhythmia, hypoxemia. Need to be explained to the patient as well as to the patient. Need to be explained to the patient as well as to the prehand.
Okay, before taking these patients OT medication, or would you avoid them altogether?
Scheduled medication, steroids and peridostigmine. Acting benzodiazepines can be given to patients with bulbar or muscle involvement. Aspirin bulbar symptoms. Receptor antagonist.
Discuss intraoperative plan. What is your anesthetic plan for this patient?
My plan would be general anesthesia with using a double lumen with regional pain blocks.
So you're going to give general anesthesia. For lung isolation, you'll be using a DLT device, and you'll be providing, including a regional block, which will be a paravertebral block, or facial plane block, isn't it? Techniques that you would use for this patient?
Monitoring techniques that I'm going to use here are ECG to rule out any arrhythmia. Patients with myasthenia gravis exhibit opioids. They are more susceptible to opioids. Opioids can be at doses, and short-acting agents like remifentanil are preferred over long-acting agents.
So neuromuscular blockers are potentially problematic in these What are the specific concerns?
There's also an increased risk of the they are profoundly sensitive to depolarizing neuromuscular blocking drugs, and they should be given an incremental guided by a quantitative neuromuscular device.
Okay, want to avoid neuromuscular blocking or technique would you use?
Sentinel can provide satisfactory conditions for tracking intubation. Induction of anesthesia with IV propofol agents, including opioids, lignocaine, esmolol, to facilitate intubation. Induction is to achieve levels of anesthesia that provide adequate muscle relaxation for intubation and surgery without the need of neuromuscular block.
Sometimes it may neuromuscular salt. For example, you have to do RSI in a patient with bulbar involvement, or if you're not getting adequate for inserting your DL, what choice do you have? Be
necessary. Rocuronium plus X is the combination and reliably reverses through encapsulation and is not affected by anticholinesterases. Reverse and carries the risk of triggering a cholinergic crisis.
and we have good evidence that Sugamadex is Myasthenia patients as well. So what was the agent of choice for maintaining anesthesia in these patients?
Anesthesia, either volatile anesthetic or a combination of both can be used. Shorter acting agents which promote early recovery and minimize respiratory depression, ketamine, fentanyl used.
Port placement for this thymectomy. She muted.
Sorry. The patient is placed in the supine position with a 30-degree lateral flexion or a partial left lateral decubitus position, angled with a sandbag pillow under the right side. The ipsilateral side of the patient in a holder. 3 5 mm ports are made. The first port at the upper intercostal space in the mid axillary, port in the anterior axillary line in the third intercostal space, and the third port in the mid clavicular line in the
Complication to anticipate prepared for your
the surgical complications during thoracoscopic thymectomy are intraoperative bleeding. There is a risk conversion to an open sternotomy-like procedure. There can be diaphragmatic injury, phrenic nerve palsy, brachial plexus injuries and neuropraxias, duct injuries, chylothorax, pericardial infusion.
So Akash, you mentioned monitoring devices that you depth of anesthesia. So why is it important and how that?
Depth of anesthesia monitoring, bispectral prevents intraoperative, particularly it optimizes drug administration after removal from anesthesia and reducing the anesthesia, which can itself trigger a.
So Akash, to perform would one lung ventilation, what will your device and what will be your ventilatory strategy for providing one lung ventilation?
I'll be using a double or a DLT in this case, it is considered to be the gold and offers reliable isolation and quick lung collapse. Is to keep the ideal volume between 5 to 6 ml per kg of the ideal body weight. The peak pressure should be less than 25 centimeters of water. Centimeters of COPD or additional. As respiratory rate is concerned, I would like to start and then start increasing the rate as to maintain normal and control of is preferred who are patients with bully, post pneumonectomy and post lung transplant patients.
What are the precautions you take during final position of the patient and before handing over the patient to the surgeons?
The patient to the surgeon, I would like to confirm once the patient is in the final secured to the operating table, head adequately avoid neurological injury, and must be taken to ensure that the are not during positioning.
No questions. I would hand over to Dr.
Thank you, Dr. Jaya. So, Akash, now we know that, from the CT scan, we found that this mass was pretty small, 3 centimeter by 5 centimeter. Now, if it appears that a big mass, how does the risk assessment differ when it represents a big mass? Risk assessment in these done according to this table right here. The risk categories can be divided as low, moderate, high, and very. Usually asymptomatic patients with a mass chest ratio less than 0.2. There is airway compression which is less than 50%.
No vascular compression is there. If the patient experiences gradual to mild to moderate symptoms and there is no orthopnea, there is airway compression of less than
50% with symptoms or greater than 50% without symptoms,
or there is an asymptomatic SVC or unilateral PA compression, these are considered to be moderate risk patients. Severe symptoms, a mass to 0.5, greater than 50% airway compression, and syndrome and dyspnea, these patients are considered to be high risk. And if there is major compression or major VQ mismatch, these are considered to be very high risk.
Okay. Yes, for very high risk patients, how do you prepare? That means, what is your approach for large compression?
The choice of anesthetic is based on the preoperative stratification. For those with high risk, the avoidance of general anesthesia and utilization is advocated if feasible. If general anesthesia is required, one should consider preoperative cardiopulmonary bypass or ECMO cannulation. Awake fiber optic intubation with placement of an endotracheal tube beyond area of compression or stenosis is advocated. Patients at intermediate risk, a stepwise induction is recommended. Administer inhalation anesthetics, heavy agents like ketamine or propofol while maintaining spontaneous respiration. Intubate from upright to supine. Once the patient is deeply anesthetic, start gentle assisted ventilation. Administer only airway ventilation is stable. Or failure at any stage, revert back to previously tolerated stage, change the patient's position, use a rigid bronchoscope, and intubate the patient distal to. In low risk case, proceed with standard IV induction or with or without muscle relaxation.
Yeah, that's nice. I mean, low risk, you can go for it, but when with airway obstruction, you go for FOV. With very, very high risk cases, you have to be ready with cardiopulmonary by ECMO setup. Correct? So now coming to intraoperative crisis management. What is cholinergic and how do you differentiate between myasthenic crisis and cholinergic crisis?
A myasthenic crisis is defined as severe respiratory or bulbar extubation or delays extubation. The intubated patient, this manifests as return of spontaneous power, a weak cough, and excessive muscle use. In dysphagia, signs of airway obstruction, shallow breathing, infection, and certain cholinergic crisis, on the other hand, is caused by too much acetylcholine at the receptors. It is often caused by a relative overdose of anticholinesterases. The high level of acetylcholine at all cholinergic bronchoria, and there is and gastrointestinal symptoms such as salivation, nausea, vomit, and diaphoresis.
In both the are pretty overlapping. Between now, what would be your management these scenarios?
For my correctable causes should be sought and treated. Alone should be instituted and taken as the first line treatment. Crisis, the treatment is aimed at antagonizing excess muscarinic. Myasthenic crisis can be difficult as is present with weak. In addition to recent events, side signs, this may be helpful.
Yes. Which may exaggerate the muscle perioperatively.
Drugs such as aminoglycosides.
What is your analgesic regimen for this patient?
Here,
Correct. So what correct. So okay. Yeah, nice. So first one is I mean one by one by one. You have to play one by one. You have to play one by one, I think. So in this first thoracic vertebral block, correct? One, the next one is three muscles, three layers are there, and subcutaneous tissue, and followed by tarsi, and followed by the center and sections. And nicely, drug is placed below the serratus and plane. Remember that the serratus anterior plane blocks are two types. Anterior plane blocks are two types. We know the serratus anterior. Or it can be deposited. And in cases we usually prefer the second. That is, we usually place the drug below the serratus anterior, just above the intercostal plane. The next one, I think, play the next one. Catheter placement. So in, I think the picture is slightly hazy. Still, you can see a thoracic it has the T4 transverse process can be seen. Now, needle, you are pressing subcutaneous tissue. Then you hydrodissect with some saline. You can place epidural nerve block catheter there. This is the placement of catheter. The next one. You can just button. ESP block spine bolus technique, and you can write the same 6 thoracic vertebra here, and drug along the vertebral level, and the ESP group of muscles nicely lifted up. Next slide, please. So, what are the regional techniques of surgeries?
Including axial and axial plane blocks to retain in the first 24 hours post-operatively.
Correct. Towards the facial plane blocks, avoiding the pure regional, pure neuraxial kind of block nowadays. Next, coming to local anesthetic sensitivity in myasthenia gravis. Which class of local anesthetic agent should be avoided in MG and why?
In myasthenia gravis, esters need to be avoided, and amides are commonly used. Esters are hydrolyzed by plasma pseudocholine esterases, whose metabolism may be because of the action of the patient's regular anticholine the patient may be taking.
Coming to extubation, can you extubate this patient on table, or would you like to do the same in ICU?
Most patients with well-controlled myasthenia gravis can be safely extubated at the end of surgery. The patient should be fully awake, has good cuff strength, and demonstrates adequate respiratory function. Early extubation preferred to pulmonary infections risks and shortens ICU stay. Neuromuscular blocking drugs, muscular monitoring used.
What specific parameters would you use to assess the readiness for extubation, or you can say extubation criteria?
Clinical signs including sustained head lift, strong hand grip, effective cuff, tongue protrusion, and normal tidal volume and respiratory rate. A quantitative top ratio of more than 0.9 standard, which ensures muscle strength and paralysis. Tidal volume is 5 ml per kg. Maximal intravenous pressure is less than 20. Expiratory pressure is more than 40.
Yeah, that's true. Did you hear this 20-30-40 rule, although not used previously? What is
the 20-30-40 rule is used to guide admissions and elective intubation during a myasthenic crisis. If the FVC is less 20 ml per kg, the negative inspiratory force is less than 30 centimeters of water, and a positive expiratory pressure of less than 40 centimeters of patient should be intubated.
now? What are the signs of phrenic nerve? How it would manifest?
Phrenic nerve injury presents with of breath, recurrent hernias, excess fatigue, difficult weaning from mechanical ventilation. Two of the following criteria should be verified to define the phrenic nerve injured after the operation. That is, there should be a description of the phrenic nerve section within the operating report, description of phrenic nerve segment during the pathological examination, or radiograph finding of an elevated hemidiaphragm, which was not there.
Correct. So before we go into the some special scenarios, is the whole anesthetic management and its challenges for myasthenia gravis cases.
So to summarize, the main aesthetic challenges in this case is the disease process itself, that is myasthenia gravis, including preoperative optimization, sensitivity to neuromuscular drugs, possibility of a cholinergic or myasthenic crisis, and postoperative ventilation. Then there are complications pertaining to anterior mediastinal mass, including airway compromise, cardiovascular collapse due to vascular structure, and then there is consideration pertaining to one lung ventilation and VATS, including placement of a double lumen tube, lung isolation, hypoglycemia, and maintaining intraoperative hemodynamic stability, postoperative pain management.
Yeah, that there is pregnancy. How does pregnancy alter the myasthenia gravis management?
In pregnancy, myasthenia gravis exacerbations usually occur in the first trimester and in the postpartum period. If or has hypertension, and one should avoid calcium channel blockers and beta blockers. If they're doing a C-section, and particularly patients with severe respiratory and bulbar weakness, they may not be able to tolerate neuralgial blockade. So in these patients, it is advisable. With a transient myasthenia gravis, these patients need to be these neonates need to be treated with acetylcholine mechanical ventilation.
Yeah, that's true. Facts nowadays there is very common robot assisted thoracoscopic surgery, and these are nowadays pretty common with these myasthenia gravis patients for thymectomy. Now, what additional considerations arises with the robotic assisted thymectomy?
And for robotic assisted thoracoscopic surgeries, the considerations are the patient's position. Again, a 30-degree right or left at the side as far back as possible, which can trigger neurobrachial plexus injuries. During regulation is used, which can obstruct venous return, cause hypertension. Again, lung isolation techniques can cause problems with oxygenation, hypoxemia, as well as surgical puncture of the internal organs. So that should be taken care of.
Yeah, that's true, but now towards more robotics. So get ready for getting the challenge. I think this session we conclude here, and for a nice session, nicely presented. Yeah. Yes, anyone.
Excellent discussion and very good speaker. I must say, Akash, good and very, very good and probing from our moderators as always. I really enjoyed this session.
Now we are moving to our next session. Akash, can you please share this slide? Now, as that video assisted thoracoscopic Nepal EM bypass. Before we proceed, we need some knowledge for produce a nice lung isolation. And when we put bronchoscopy or through mouth, we reach hypopharynx. The carina we can the right main bronchus. Then we rotate the scope clockwise to see right main bronchus. You can see the upper lobe, right carina 1, middle lobe, and right lower lobe. That means 3 apertures. Then we go into the right upper lobe. There we can see the right upper lobe RB2, and when we come back and go into the far deeper down there, the lobe and in between right carina 2, and then on the right basal branches and apical segment of the basal. Trachea anti-clockwise 90 degree and by left carina 2. The upper one is lingual and the lower one is left basal branch. And when deep down into 6, 3 further division B, LB6C. When we come back from there to go upwards, we can see again 2 divisions, left upper bronchus, LC1, and is the basic anatomy for bronchoscopy we must know. Next, I would like to invite Dr. Sayantan. Dr. Sayantan.
Everyone. So I will be successfully. Repositioning is rarely required. Bronchoscopy and suction lung can also we can apply CPAP or to the either lung is very easy. So it is the